All right, well, thank you. Yes, I'm Wendy Gibbs. I'm at the Mayo Clinic in Arizona, and I'm a neuroradiologist, and my primary interest is spine radiology. And as you just heard, I recently came from Los Angeles, where I was at USC and head of spine imaging and intervention. So this is my primary interest. I do all of neuroradiology, but this is a topic that I think is one of the most important. So I'm glad that I get to share this with you. Spine infection and mimics, important even though relatively rare, because it often goes undiagnosed or the diagnosis is delayed. And when that happens, morbidity and even mortality can be substantial. So it's good to see some of these different manifestations of the disease and how we can treat it. All right, so I'd like to start out with a case. This was a 56-year-old woman who went to her primary care doctor. She lived in kind of an underserved, for California, an underserved area. She went to her primary care doctor. The doctor examined her and got this x-ray, neck pain. Neck pain was the indication. And the problem at this particular site or in this area was that the radiograph did not get read for several days. They did interpret it correctly. They said there's normal alignment of the spine. The vertebral body heights all look good. The discs all look good. The only real abnormality was the prevertebral soft tissues are very prominent. Now this was an abnormality, but somehow this information did not get conveyed to the doctor or perhaps from the doctor to the patient. So she went home and, I don't know what happened. 3 weeks later, she came to our emergency room. And this is what her neck looked like at that time. I flipped this radiograph around so it was the same as the CT. When she came to our yard, she went straight to CT. 3 weeks, you can see how much her spine has changed. At this level right here, C3, C4, you can see compared to the prior, she's completely lost disc space height. The vertebral bodies are being destroyed. There's new subluxation, there's retropulsion of this vertebral body into the canal. And the prevertebral soft tissue swelling, probably even more. Now, somehow she got a post-contrast CAT scan as well. I'm not quite sure why that happened, but she did. And on this one, you can see the same findings, except you can also see the enhancement in the prevertebral soft tissues, as well as in the epidural space, probably compressing the spinal cord. Here on her axial post-contrast CT, you can see the same thing, some epidural abscess or phlegmon and prevertebral abscess as well. Then she went to get her MRI, and this shows very classic findings of spine infection on MRI. So at C3, C4 on this sagittal T1 weighted image, you can see that 3 and 4 vertebral bodies are T1 hypointense. Here we have a sagittal T2, and this nicely shows how much compression of the cord and canal stenosis there is from this process. You can see the CSF is completely effaced. There's no signal abnormality within the cord yet, luckily for her. This is a sagittal T2 fat saturated image or STIR image, and this takes out all the fat in the vertebral body marrow. So it really nicely shows the edema or infiltration of the bone marrow in the spine. And you can see it completely infiltrates those bodies. Here we have a sagittal post-contrast MRI with fat saturation. And this shows you the avid enhancement within the vertebral bodies, within the epidural space, within the prevertebral space, this big prevertebral abscess. And here's our axial post-contrast. You can see the same thing. Prevertebral phlegmon, epidural phlegmon. So again, this is the progress, very fast moving infection. And you can see it's very good that she got into the ER when she did, because spine is unstable. At any moment, this could fail, give her compression of her cord, significant morbidity, even mortality. This could kill her. So because the spine was unstable, because it was moving so rapidly, she went right to surgery and got an extensive surgery. She got a big corpectomy. They removed the bones. They put in a fibular graft. They put in anterior plate and screws right here. This is a surgical drain. And they put in posterior lateral mass screw and rods. So spondylitis, like I said, it's not terribly common. And this is in the US, actually. It might be more common where you are. I don't know, and I'll be interested to hear. The interesting thing is it's relatively easy to treat, but yet we still have bad outcomes. And why is this? Often diagnosis is delayed and treatment can be suboptimal. There's no real classic history. The symptoms can be subtle, they can be nonspecific, they can come on insidiously, slowly, or acutely. There is an inconsistent approach to both the diagnosis of spondylitis, discus osteomyelitis, and an inconsistent approach to treatment as well. And oftentimes necessary studies and services can be delayed, like the radiographs, like this story I just showed you with that woman, where her radiographs maybe got read, but the information did not get conveyed. Diagnosis, these are things we learn in medical school, so I'm not going to go over them too much, but we know that we need the history, the exam, the laboratory results, and imaging. All of these things are key. A very large number of symptoms. They can be nonspecific. It might be focal. You might have systemic symptoms depending on what type of infection, how long you've had it, like lethargy and anorexia. You may or may not have fever. Maybe 50% of people do. If it's severe, you might have focal neurologic symptoms like weakness, radicular pain. You might have trouble walking, even bowel and bladder dysfunction, Coccidioidomycosis syndrome. Risk factors. It's said that if you don't have one of these risk factors, the chance that you have discus osteomyelitis is actually very rare. For us in the United States, diabetes is the most common. But any other risk of bacteremia, like drug use, any kind of device you have, medical device you might have in your body, immunosuppressed patients, patients with cancer, patients with systemic diseases like cirrhosis, chronic kidney disease, HIV/AIDS is a big one. And then interestingly, history of spinal trauma, fracture, repair, surgical repair, or spine procedures, which I actually do a lot of these, and we're very careful about injections, pain injections, and other foci of infection in the body. Now, this is an algorithm. I don't know how well you can see it, but that's okay, because I just want to go over it very basically. And this is an algorithm I wanted to implement in my old institution, and we're probably going to implement in our new institution, that will make the treatment, the diagnosis and the treatment more algorithmic. At the beginning, I said that it's often underdiagnosed and undertreated because there is no standard way to approach this. So maybe if we can fix the standard approach, we'll have better luck. So when a patient comes into the emergency room or wherever they're going to be treated, if they have this new onset of back pain, and the ER doctor, I'll use in this case, is very suspicious for discus osteomyelitis, then the first thing they need to do is get a complete neurologic exam. And even though that seems like that would make sense, it very often does not happen. In addition, they need to get a standard set of labs, the CBC, the sedimentation rate, C-reactive protein, blood cultures, urine culture. That needs to be done right away. And at the same time, we get ready for imaging. So the imaging, it depends what you have available and what the patient can get. Imaging can be an MRI, that's the very best. But if you can't get an MRI, a CT myelogram can work, can show you what might be compressing the thecal sac. A CT with contrast, kind of as a last resort, is better than nothing. So what we do after we get these labs, after they get the neuro exam, if they have a normal neuro exam, we will want to image them within 6 hours. Now, again, this is the United States. This is maybe a larger academic center. This isn't even going to happen everywhere in the United States. If they're a community hospital, somewhere where imaging or anything is not, services are not as available. But here, 6 hours. If imaging is normal, it might not be discus osteomyelitis. The ER doc needs to find a different cause. And if they still think that the person is infected, they'll come back in a couple weeks. If the imaging shows that there is imaging evidence of discitis, then we want to get ready to do a percutaneous biopsy of that disc. And that's radiology, that's me. So hopefully we can get it done within 24 hours because we want them to wait on any antibiotics until we get that biopsy. Once they start antibiotics, the chances of us finding out what the organism is decreases very rapidly. Now, if we get the imaging, the MRI, and there is an epidural abscess, this person needs to go to see neurosurgery or a surgeon of some type. Also, if they're unstable anyway, if they have sepsis, or if their spine is unstable, like the first woman I showed you, where she had the new subluxation and the canal stenosis and cord compression. Those people don't come to us in radiology for biopsy. They need to go see a surgeon. So what are the indications for surgery? Again, any kind of neurologic deficit, bowel and bladder incontinence is a big one, Coccidioidomycosis syndrome, radicular pain, weakness. If they have sepsis, they shouldn't be coming to us in radiology for biopsy. They need to go get evaluated by a surgeon. Deformity or instability, as in this case. And for instability, we consider that of greater than 50% collapse of the vertebral bodies, greater than 20% angulation of the spine, or greater than 5 degrees of translation. Also an indication for surgery is failed medical management. Now let me give you another case. This was a 39-year-old man with HIV, and he had drug abuse, and he came into the ER with symptoms of Coccidioidomycosis syndrome. So his issue was he had a pacemaker, so he could not get an MRI in the middle of the night. He also had an INR of 4, so he was coagulopathic, so we could not do a myelogram. So the neurosurgeons and the ER doctor are like, what do we do for this patient? This is a case where CT with contrast is better than nothing. So you can see on this CT with contrast that this person has, I hope you can see this, it's very faint, a large epidural abscess. This is the outline of it right here on the sagittal CT with contrast. So this was a nice test. A lot of people think you can't see it on this, but you can. Here on this axial image, here is the epidural abscess. So the ER doctor was right. This was causing his Coccidioidomycosis syndrome. Now he went to neurosurgical consultation. Because of his comorbidities, I don't think he got surgery. I'm not sure how he did. All right, so lab results. These are the labs that I told you we should be getting. White blood cell count. Typically, it's mildly elevated, but if you have a pediatric patient, an elderly patient, or an immunocompromised patient, it might not be. So that doesn't always work. Sedimentation rate and CRP. These are pretty sensitive and specific tests if you can get them. The CRP, C-reactive protein, is probably the best because after the onset of infection, it rises most quickly. And after infection is treated, it normalizes most quickly. So if you can get that, do. Blood cultures, 50%, maybe half the people have positive ones. And if it is positive, it's probably already a pretty bad infection. Now, this is an interesting study that came out from my friends from Thomas Jefferson in Philadelphia last year, and I'm going to reference this later in the talk. But I'm using it here to show you the point that if a person has normal labs in terms of ESR and CRP, it's very unlikely that they have discitis osteomyelitis. How about different types of imaging? I'm going to go back to this, radiographs. Radiographs are not useful, although in many parts of the world, it's all you've got. So in the acute phase, it's probably going to be normal. Subacute, 1 to 3 weeks, you may start to see some end plate irregularity, some loss of disc space height. This is progressing over a number of weeks and months. Chronically, you will start to see sclerosis in the end plates. You'll get more collapse. You might have more deformity of the spine. So really, they're not useful until this infection is well established. But if that's all you can get, that's what you get. CT is a little bit better. With CT, you see end plate destruction. You see demineralization, lysis of the bone. You can see soft tissue calcifications, which is useful in tuberculosis. And as I showed you before, with contrast, you can see abscess. Now, MRI is the best if you can get it. So in terms of the disc, you'll see T2 hyperintensity. Now, normal discs can also have T2 hyperintensity. This is a normal disc in the thoracic spine. But in the normal disc, you can see in the middle, there's this dark line, which is a normal intranuclear cleft. When you have infection in your disc, you can see this one, which is infected, discitis, is much brighter, and it's lost that cleft. So this one you know is infected. You might have prevertebral and paravertebral T2 hyperintensity and enhancement. You might have edema and abscess. And in the epidural space, again, phlegma, if it's enhancing but no central area of non-enhancement. If there's a central area of non-enhancement, that probably means it's an epidural abscess. And then finally, you have marrow edema. This is a sagittal post-contrast fat-saturated image. And this shows both the enhancement and we'll have edema as well. Now, PET scanning is a useful alternative to MRI if you can get it. We don't actually do this. As a neuroradiologist, I actually don't read these. But it's also good for patients who might have spinal hardware, who are also predisposed to infection. So screening at additional levels. This is the interesting study I referenced a few minutes ago from Jefferson. So if a person has discitis osteomyelitis at one level, like in the lumbar spine. It's established, they know that's what it is. They've argued that you the entire spine. So, a little bit loud. In their study, they had an area of discitis osteomyelitis. They got a fast protocol where they got sagittal T2 weighted images and T1 post-contrast images of the rest of the spine. They found that 25% of those people had another site of discitis osteomyelitis somewhere else in the spine. Of those, over half went to surgery, so it significantly changed management. So this is their protocol, and it's kind of a long one, but it's interesting, and I think that it's useful. I'm going to show you my own version of this. We did not have this protocol, but this happened somewhat incidentally. This was an orthopedic surgeon at my old institution, and he had back pain. And so because he was a doctor at the hospital, he got his whole spine scanned because he was kind of a VIP. So this was the level of his pain. Again, classic findings of discitis osteomyelitis. There's destruction of the end plates. There's loss of height of the vertebral bodies. Here on the sagittal T2, you can see it's very hyperintense. This is the picture I showed you a few slides ago. Here on the fat-saturated T2 weighted image, you can see edema within the surrounding vertebral bodies. And here on the post-contrast fat-saturated image, you can see that there's a little bit of enhancement and there's a little bit of epidural enhancement. Very unusual appearance on the axial image where there's enhancement in the paravertebral and epidural space. So he got imaged at the other levels, like I said, just because he was a very important person because he was a doctor at the hospital. And indeed, even though he did not have lower back pain, he also had another site of infection in his lumbar spine. Enhancing disc right here, enhancing vertebral bodies. So this was also infected. We actually biopsied this one as well, and it was. So even though we don't have that screening protocol, it might have been useful. So if we can do that, that's a good test. Okay, so let me give you another case. This was a 76-year-old man. He was, he was from Mexico, and he came up. He was visiting his family. He had increasing back pain and had new urinary incontinence and leg weakness. So he had neurologic symptoms. When he came to the ER, he had an abnormal neuro exam. So we got him right to MRI. And here we can see the classic findings of discitis osteomyelitis, sagittal T1. Vertebral bodies are T1 hypointense. You lose the cortex here. You see, you can't see that black cortical line anymore. Here on the sagittal T2, you can see that there's T2 hyperintensity within the disc. Here's our sagittal post-contrast, fat-saturated image, enhancement within the vertebral bodies, actually this vertebral body as well, L4, L5, S1, enhancement within the disc. And in the epidural space, we see there's also enhancement. Here on the axial image, epidural enhancement. I think there's a little hypoenhancement in the middle, so that is an epidural abscess. He also had psoas abscesses. So he went to neurosurgery. Because this was a rapidly progressive process with an epidural abscess, they went right in, they did surgery, they cleaned him out. Then they sent him back to me to take care of the psoas abscesses. So I put in pigtail catheters to drain those. And he did very well. Actually, he also had wrist pain and knee pain, and they drained his wrists and his knees as well. And this was Staph aureus. This is 6 weeks later, and you can see how much better he's doing. This was previously T1 hypointense, a lot of edema in the bone marrow. And now you can see the fatty marrow, T1 hyperintense fatty marrow, is already returning. Here on our post-contrast images, there's still a lot of enhancement, but it's better than it was. And here on our fat-saturated T2 image, there's much less edema. Here on our axial post-contrast image, there's still a little bit of enhancement, and that's expected because that'll last a long time, but it's better than it was, and that epidural abscess is gone, and the psoas abscesses, so good for me, yeah. So pyogenic spondylitis, like this case with Staph aureus. This is the most common in the lumbar spine. The spread is hematogenous. It can come from urinary tract infections, skin infections, respiratory tract. It can be transvenous, a little bit less common, or it can be direct if you've had surgery or interventions of some type like pain injections. 50% or more are Staph aureus, and methicillin-resistant Staph aureus is a large number of these. 10% are a number of bugs. Interestingly, degenerated discs, where you see modic changes or active type 1 end plate changes, those are predisposed to infection, and that may be because there's increased vascularity. Also, discs have been operated on, maybe for the same reason as they're healing. They have increased vascularity. Those are predisposed to infection more than normal discs. So here's another case. Again, sagittal T1. I'm going to show you a lot of cases because it often looks the same. We have T1 hypointensity, loss of that black cortical line here between the bodies along the discs. The fat-saturated T2 weighted image. There's edema within the bodies. Post-contrast fat-saturated image, enhancement, and epidural enhancement with central non-enhancement. That's an epidural abscess. Here on the axial post-contrast image, again, you can see an epidural abscess and paravertebral enhancement as well. This is a nice CT case. This is non-contrast. When this guy came into the ER, we knew he had a problem because look at this, very unusual. You don't even need contrast to know what's going on. So his spine is somewhat well aligned, but here you can see there's loss of the disc space height. There's retropulsion of this body into the canal. Very unusual appearance of the prevertebral soft tissues. We know this is going to be an abscess even without contrast. He went to MRI, and you can see indeed on the sagittal post-contrast fat-saturated image, this disc level, he's got enhancement in the disc. He's got a very large prevertebral abscess, so enhancement, central non-enhancement, and an epidural component as well. Now contrast this with granulomatous spondylolischitis, and this is common here somewhat, but it might be more common in other parts of the world. I love this picture because it's just like a figure that I got from a book. Granulomatous discitis is different because instead of it being centered within the discs and then spreading to the bones, the discs are often spared early, and that's because it lacks proteases to enter the disc and infect it. So in granulomatous, which is mostly tuberculous, we have subligamentous spread, and we can have skip lesions as it goes subligamenously to other regions of the spine. So here we have that fat-saturated T2 weighted image, and this is nice because it's just like the picture. There is a little bit of T2 hyperintensity in the disc, but you can see it's mostly spreading onto the ligament. Same thing here on this fat-saturated post-contrast image. A lot of enhancement in the body, subligamentous abscess, but really the disc, there's height loss, but it's not that bad as we saw in the pyogenic abscess. Here on the radiograph, you can see why radiographs are not quite as useful. This is actually, where is it? It's right here actually. We have some height loss and sclerosis, but boy, that is hard to see. If you knew the patient's pain was there, maybe, but boy, if you're just looking at x-rays real fast, you might have missed that one. Much easier to see on CT. You can see the marked destruction of this vertebral body, fragmentation, and sclerosis. Here on the axial CT, again, you can see the marked destruction and sclerosis caused by granulomatous spondylolischitis, much more than pyogenic. Here's this guy's MRI. So on the T2, you can see the destruction, the kyphosis, the soft tissue component going back into the canal, compressing the spinal cord. Another reason why it's so important to get these treated early, because they can progress very rapidly with very bad outcomes for the patient. Here's the post-contrast fat-saturated image where we have enhancement and destruction of these vertebral bodies and an epidural abscess. Here's another case of granulomas. This was tuberculous. I don't have that many cases, but those that I do have are very unusual. So sagittal T1, it's hypointense in the body, hypointense in this body, and this body as well. So 1 and 2 and 3. Marked destruction, marked deformity with focal kyphosis and loss of height. There is some retropulsion in the canal. At this point, it wasn't so bad. But here on T2, you can see there's not really any T2 hyperintensity. Here on the post-contrast image, you can see that there is some enhancement, but the discs are really okay, so it's a disc-sparing disease. Here's another case. This person had HIV/AIDS, very young man. Unusual appearance of the spine on the CT, so you can see the vertebral body heights are okay. Alignment is okay. Disc spaces are okay. This is not a disc-centered process like pyogenic spondylolischitis. But look at the bones. These are very large, we don't know what they are. Are they infarcts? Are they granulomas? I'm not sure. We don't know what they are. Here on the, this is actually the soft tissue window, you can see, again, the very unusual appearance of the bones. The discs are okay, but he does have an epidural abscess as well as soft tissue abscesses, cold abscesses within the subcutaneous tissues and the psoas muscle. So this tuberculous spondylitis is the classic granulomatous disease, hematogenous spread. Again, it starts in the subchondral bone adjacent to the end plate with subligamentous extension and can have skip lesions, so you can see it all over the spine. The discs are spared early, although they are affected in the end. And you may have those caseating granulomas. This is a pathology slide in the marrow. Now this is a chart that hopefully you can see it. There's a lot of information here. These are some of the differences between pyogenic and tuberculous, but really it's oftentimes hard to tell. Things like they say that pyogenic is usually one level, whereas granulomatous is multiple levels. Well, every case of pyogenic I've shown you so far was actually more than one level, so that rule doesn't really work. Imaging for pyogenic, primarily disc destruction, whereas tuberculous is primary osseous destruction. That might be a good rule. Vertebral body enhancement. I think those, it's very hard to tell. They say maybe pyogenic is more homogeneous, where tuberculous is more patchy and heterogeneous. This comparison right here is nice because this is pyogenic and shows kind of the diffuse enhancement within the vertebral body. This is granulomatous, and this is more heterogeneous, and this is actually an abscess within the bone. Now this did go into the disc eventually, but that was late in the process, and this is another abscess within the bone. Abscesses in the bone don't happen in pyogenic, so if you have this appearance, granulomatous is a good bet for this person. What about the abscesses? They say that the abscesses in granulomatous are maybe more well-defined and loculated, although I showed you the case of the man whose abscesses I drained who had SAF, pyogenic discitis osteomyelitis. His looked just like this. All right, so what about this case? This is another granulomatous case, but it's not tuberculosis. This was a young woman, 16 years old. So you can see on her sagittal T2, marked disease everywhere. In the bones, she has heterogeneous T2 signal in the discs. You can tell that she has abscesses here, presacral abscesses, epidural abscesses, soft tissue abscesses. Here's her post-contrast fat-saturated image showing those findings again. Large presacral abscess, abscess in the thecal sac, extending dorsally, epidural abscess, bone abscesses. Here on her axial post-contrast, epidural abscesses, soft tissue abscesses. Horrible, horrible disease. This is Coccidioidomycosis. Now, when I trained in Arizona at the Barrow Neurologic Institute, this is one of the endemic areas for Coccidioidomycosis, or cocci, I'll say, because it's hard to say. I rarely saw tuberculosis, but this was much more common. This isn't very common most places in the world, but maybe where you are, it is. This is fungus, dimorphic fungus, Southwest US, Central and South America. It's more common. This is actually a lung disease, but when it disseminates, if you maybe are one of the populations at risk, if you're elderly, young, immunosuppressed, or some of the countries, people who come from Africa or Filipino populations are more predisposed to this disease. And when it gets disseminated, you can have meningitis, you can have spine disease, you can have bone disease anywhere. 10% of those disseminated diseases do go to the spine. And when it's in the spine, it can be very bad. This was a 40-year-old woman who had coccidioidomycosis. It had been treated in time, fortunately, but look at the deformity it left. She got surgery. She doesn't have cord compressions. She's okay in terms of her spine, but you can imagine that's not a very comfortable way to have her neck. And she has to be on lifelong treatment for this disease. The last case I just showed you of the 16-year-old girl, she was of Filipino descent and she had stopped her medicine, and that's why her disease disseminated so rapidly. And she'll also be on medication for the rest of her life. Now this is unusual because it has features of both pyogenic and granulomatous discitis osteomyelitis. So it can have permeative or punched out lesions on CT. Often the discs are spared early, like granulomatous. You can have heterogeneous or diffuse enhancement, and you can have a lot of abscesses everywhere, as I showed you. Now this is another case. This one is very rare in the United States, and again, it might be more common in other parts of the world. This is a man, this is Bruce, and Bruce is a dairy worker from the Philippines working in New Zealand, and he's drinking a glass of unpasteurized milk. That's the clue to this case. So here on our sagittal T2, he's got a lot of edema, or T2, a STIR, T2 fat saturated image, a lot of edema within the vertebral bodies, but the disc is spared, so it's more like tuberculosis. Here on our post-contrast image, fat saturated, a lot of enhancement in the vertebral bodies, epidural enhancement with a little non-enhancement, so that is an epidural abscess. Here on our axial post-contrast, epidural abscess and a psoas abscess. And but unlike pyogenic, the discs are spared, the end plates are spared, the vertebral bodies aren't losing height as we saw in those more destructive processes. So this is brucella. Again, it's very rare in the United States, but it's more common in other places. So this is a zoonotic infection. It can come from the respiratory tract, GI tract, dairy workers who might get abrasions when they're working with their animals, farmers, veterinary workers can get this, or people who drink unpasteurized milk. And in the United States, that happens most frequently in Texas and California, where people drink milk that has come in from Mexico. So I've added this to my list. Pyogenic, tuberculous, as I already discussed, and brucella, much less common, but if you have an exposure history, if you're a veterinarian or if you work with animals, again, the vertebral body is preserved, unlike granulomatous or pyogenic. It often happens in the lower lumbar spine. I showed you coccidioidomycosis can look like tuberculosis, can look like pyogenic, or it can look like metastatic disease, can look very bad. Again, think of this when you're in an endemic area. You have lytic lesions, can spare the disc, multiple abscesses. Sarcoid I took out because that actually doesn't look as much like infection as it looks like metastatic disease. So it's still in my chart, but I'm not going to show you a picture of that today. Now, what about post-intervention infection? This is something I see a lot, and I saw a lot where I was before in California because we had a very large spine center, did a lot of spine surgery. This is a young one, 40 years old, who got a discectomy at L5S1 for a disc protrusion. She had a lot of pain 3 weeks after surgery. She went into an outside hospital, and this was her imaging. So very hard to tell. She had surgery there. When she has surgery, they dig out a little bit of the end plate, they dig out the disc. So maybe this is normal postoperative appearance. It's hard to tell, although it's a little bit primitive. I'm not sure. Here on our sagittal T2 fat saturated image, she has some edema there. She has T2 hyperintensity in the back of her disc, but this can be normal post-op. Here, this is a post-contrast fat saturated image. She has enhancement in the end plates surrounding that level. That can be normal. So because her symptoms were really bad, she got a biopsy by radiology. We didn't actually do this. This was an outside institution. And it came back negative. So she went home. But then 3 weeks later, she came back. I'm actually giving the answer down here. Came back, and it was much worse. So now you can see this has the classic findings of discitis osteomyelitis like I showed you before. Much more T1 hypointense, loss of that cortical line, that black cortical line on T1. There's more T2 hyperintensity in the disc. There's more enhancement. And actually, here you can see there's much more soft tissue enhancement now, much more enhancement in the disc, even going out to the epidural space. And she indeed had a little bit, I don't show it here, but she had paravertebral enhancement. She did have discitis. She also had an abscess in the soft tissues back here in the surgical bed. So this is relatively uncommon, only, up to 4% of procedures. So uncommon, but when you do a lot of spine surgery, it's a very common indication for imaging. Most common either a skin flora, epidermis, staph epidermidis, or staph aureus. And it can be bad if it's not treated because if you got an implant surgery, like a graft, you can have implant migration, or you can have subsidence where it collapses around the graft, or pseudoarthrosis, or the spine can be unstable and you need to get more surgery. This is much more common if you actually get instrumentation, screws and rods. Usually these people are okay and they go home, they have pain from their surgery, but about a month later they come back with severe pain. And it might be the pain they had, or it might be a different pain. And that's when you need to worry. It's a different pain than they originally had. Now, normal postoperative spine, you can have a T2 hyperintense disc, you can have linear enhancement. I'm sorry, I don't have a picture to show you of this. Or you can even have nerve root enhancement, and that's okay post-op. But if you have enhancing paravertebral soft tissues or epidural soft tissue, that's not normal and very concerning for infection. Or loss of that end plate definition, as I showed you on that last case. And as you can see on the CT, when this person originally came in, we might have suspected there's kind of a lot of lytic demineralization here, which is concerning for infection. Now let me do infectious synovitis. So this was a woman in the cervical spine. She injected drugs. Let me go back. So she had infection focused on this facet right here. So back here, you can see all the enhancement around it. Here, a little different cut. You can see she does have a rim-enhancing abscess. And here on the sagittal post-contrast, you can see the infection actually went into the spine in the epidural space dorsally. Here's a very large abscess right here with air in it. So here's another picture. These are things that we can biopsy. This is something I do. We biopsy it, we drain it, treat it the best we can, and then they can get antibiotics. So this is her laying on her stomach, bringing this needle right here to the area of the abscess, and we drained this. Facet synovitis, 4 to 20% of spine infections, so much more common than most people think. Usually it's hematogenous spread of infection, although if the person either injected drugs with a needle or if they maybe had a facet injection for pain relief, that can cause this process. Usually it presents more acutely than discitis spondylodiscitis. It's unilateral. Most of these people are febrile, unlike discitis. And we often find the organism in these cases as well. Blood culture is positive at 90%. And a good number of these can get paraspinal and epidural abscesses, so they can be quite dangerous. So complications, speaking of epidural abscess, this is the most feared complication from spine infection. Very high morbidity and mortality, up to a third of patients. People can become paraplegic, quadriplegic if they're not treated. And this can be either because of spinal cord compression, but also added problems because of vascular issues related to the infection. They can get arterial occlusion, they can get venous thrombosis, they can get vasculitis. All these things add to the cord edema and cord damage. Treatment. If they don't have an abscess, say this was just enhancing without the central non-enhancement, so it was actually just phlegmon, those might be treated conservatively with antibiotics. But if they have an abscess, typically they're treated with surgery. Not always, but often that's the best course of action. Here, again, this picture right here, you can see this epidural abscess dorsally, enhanceable, a central non-enhancement. So this case, so again, this one came into the ER. We are suspicious, even though we don't have contrast here, we can see there's loss of disc space height. There's a little bit of loss of the end plates right here, prevertebral edema. Here on our axial, we can see there's a lot of prevertebral edema. So, you know, it's not terrible, but we're a little bit worried about this guy. So he went to MRI, and look how bad this is on MRI. You never would have guessed this on CT, actually. Huge epidural abscess. This is a sagittal post-contrast fat-saturated image. All this enhancement with central non-enhancement in the ventral epidural space. Abscess throughout the length of the cervical cord, as well as the prevertebral space as well. Here on the axial post-contrast, rim enhancement, central non-enhancement, compressing the cord. Because this was such an extensive process, he got a pretty extensive surgery. So corpectomy, large cage placement, anterior plate and screw fixation. Another complication, instability and deformity. So this was a case I showed you before of TB. This guy had been treated, so they thought his infection was under control. But even though he was treated, he went on to fracture this vertebral body above the level of infection, retropulsion, compression of the conus, neurologic deficits. And he actually got treated, so he was okay. But this can collapse, and even after the spine is treated, have bad results for the patient. This person, young woman, 40-year-old, she got this scoliosis surgery, extensive construct in the lower lumbar spine, severe back pain. She came in on this radiograph. This is kind of small, you probably can't see it, but she had junctional failure right here. She actually had some problems with the hardware as well as a compression fracture. When they went in to fix her, they found that she had E. coli. So a very unusual cause of infection, but another cause of post-op spondylodiscitis. Now let me talk briefly about biopsy, because whatever we see on our imaging doesn't really matter. We try to diagnose this, but usually we're going to need to get tissue. And we can do this as radiologists. A word about percutaneous versus open biopsy by the surgeons. Percutaneous, a lot of my colleagues don't like to do it. They say it's never positive, but it is positive up to half the time. So it's much faster. People can come into our outpatient centers. They can get it done in half hour. They can go home in 2 hours. Cheap and relatively easy for the patient. Lower morbidity. Yield is a little bit less than surgery, but my argument is if we can get this way, 50-50 chance, patients are better off trying this first. What we try to do is get both the disc and the end plate, and that'll have the highest yield for finding the organism. Now, there are a lot of papers in the literature about this, numbers all over the map about the true yield, but this was a nice meta-analysis from my friend Ashley Srinivasan at Michigan. They published a few years ago. And so this suggests that before antibiotic treatment, if we biopsy these, our yield's about 50% versus open surgical, which is 75. Not too bad, not too different. If they've had antibiotics, though, the yield drops to 30. And that's why we want to get this imaging and biopsies done as quickly as possible. Follow-up. This is an important point. Imaging findings lag behind the clinical symptoms by months. So when these people come back for follow-up, go by how they feel, not by the imaging. When they're recovering, the very earliest signs of healing in Coccidioidomycosis osteomyelitis are a decrease in the surrounding soft tissue component and reconstitution of the T1 hyperintense fatty marrow. So this was a case from earlier. This guy had osteomyelitis in his body, T1 hypointense. You can see 6 weeks later, it's becoming T1 hyperintense again. This marrow is coming back and he's healing. If they have persistent or even increased enhancement, that doesn't necessarily mean they're worse. If there's clinical improvement, that's what we need to go by. So here's an example of that. I think this kind of proves the point, I hope. This is a 40-year-old man who had increasing back pain. He was a drug user. So this classic findings, T1 hypointense, loss of the cortex, collapse, T2 hyperintense, edema within the bodies, enhancement in the disc, epidural enhancement. Here's our axial epidural enhancement. So he actually did have an epidural phlegmon. They treated him actually, I think somewhat suboptimally with oral antibiotics. He should be getting IV, but they sent him home. He got a biopsy. Sorry, he got a biopsy. It was actually negative. We didn't get a result, but they still sent him home with his antibiotics. He came back 3 months later, feeling great. He was fine. He was better, but they got him imaged anyway. Look at these pictures. Sagittal T1 post-contrast looks exactly the same. Enhancement in the disc, enhancement epidural, enhancement disc, epidural. 3 months later. On this axial, epidural phlegmon. But he was totally better clinically, so they didn't do anything. They sent him back home. So my argument is, really, do we even need to image them? Probably not. But even if there's similar or increasing enhancement, it doesn't necessarily mean that their disease has gotten worse. So this was that surgeon I showed you, got the full spine. I'll just go through this quickly. Let me just show you the axial images, axial post-contrast. Again, this was a very unusual appearance of the implant, called those weird little holes. A paravertebral enhancement, epidural enhancement. 5 months later, looks exactly the same, but he was better clinically. So they didn't do anything. They didn't keep treating him. All right, in the last few minutes, just a couple minutes left. Here I'm going to give you some quick mimics. This was a young woman who came in with neck pain. Her sedimentation rate and her CRP were negative, so negative inflammatory markers. Does she have Coccidioidomycosis osteomyelitis? Sagittal T1 hypointense, edema on the STIR image, enhancement. So no. So she had degenerative changes. This is the most common mimic of Coccidioidomycosis osteomyelitis. If you get, it can be T1 hypointense, it can have edema, and on post-contrast images, it can enhance. But you know it's probably going to be the degenerative changes, type 1 modic changes, if you have a more well-defined area of abnormality, rather than the diffuse enhancement and edema we saw with infection. If you have vacuum disc, air in the disc, very unlikely that that's an infection. And if it's T2 hypointense, less likely that that's infection. Many of those still go to biopsy if they're very controversial cases, but some of those tips can help us distinguish. I'm going to skip the claw sign because I don't know how many people do diffusion, but this does the same thing as the STIR images. You have well-defined areas of diffusion or STIR hyperintensity if it's degenerative change versus more diffuse if it's infection. If you can't get contrast, the psoas sign that shows T2 hyperintensity within the psoas muscles, more likely to be infection than degenerative change. You're much less likely to have that with the modic changes. I want to get to the rest of the mimics in the last few minutes. This one is actually, I'm going to go quickly through these. This is the only case I've seen of this, dialysis-related spondyloarthropathy. The disc is not very bright. If you have a person that has punched out lesions, they have severe pain, but they've been on dialysis for a number of years, more than 5 years, and they might have abnormalities in other joints. This can be this very rare dialysis-related spondyloarthropathy related to amyloid deposition. Happens in most of the large joints. T1 hypointense, T2 hypointense because of the amyloid, punched out lesions without osteophytes. Most common in the cervical spine. I've actually only ever seen it in thoracic spine, but it can happen anywhere. This case, somewhat similar. X-ray, CT, you can see there's a disc-centered process, a lot of end plate destruction, deformity. Here on the sagittal images, you can see there's enhancement around it, central non-enhancement, like a big abscess. This is spinal neuroarthropathy. This is when you can have spinal cord injury and you've lost this protective sensation. When you hurt yourself, you don't know it. So you get repeated trauma. And this is can happen also in all the joints. And this is what it looks like when it happens in the spine. Number one cause is traumatic spinal cord injury, but you can also get it from diabetes, syphilis, and syringomyelia. It's very confusing because it's an unusual appearance and it can happen any number of years after you get your injury and after this process begins. So on X-ray, prolific bone proliferation right here around this person who had a spinal cord injury from a motorcycle collision. Density, destruction, deformity. Those are the D's we learn in medical school. Here's another case. This one, T2 hypointense disc. So although this looks somewhat like infection, disc isn't T2 hyperintense, so we're a little bit less suspicious. Again, prolific bone formation on the X-ray and on the CT, destruction. This is a mimic because actually this was a CT case that I showed you before, tuberculosis. This spinal neuroarthropathy looks somewhat similar. Last couple ones here. So this was a young woman, actually I think 50-year-old woman, sorry, yeah, young. So she had severe back pain, sagittal T2. We have this unusual appearance here, T2 hyperintense disc, T2 hyperintensity in kind of a ring-shaped configuration around the disc. T1 hypointense and enhancing. Does she have discitis osteomyelitis? Schmorl's notes, acute Schmorl's notes, unusual, but this can also mimic infection. You can have marrow-edema, you can have marrow enhancement. But if you have that ring and it's in the end plate like that, that's a clue that can help you out. But again, sometimes it can be hard to tell. Often it's one end plate, but I just showed you a case where it's two, so you never know. Here's another one, T1 hypointense, stir hyperintense, and actually this is stir hyperintense, T2 hyperintense. Last two cases real fast. So sagittal CT, this person had severe neck pain. Here you can see this little calcification on the axial at the level where the ligament inserts. Here we have, you can barely see it, a little bit of fluid here, a little bit of fluid here. Calcific tendonitis of the longus coli is another mimic. This is an inflammatory granulomatous response to calcium hydroxyapatite crystals in the longus coli tendon. This calcification at the level of the tendon insertion is classic, as is the prevertebral edema. Important to diagnose, not think this is infection. It's very easily treated with non-steroidal NSAIDs like Advil. They can have elevated white blood cell count and sedimentation rate, so it can be very confusing. And on MRI, which I don't have a picture of, it can look very much like infection, but you should have a thin rim of enhancement and not a thick rim like you might see with an abscess. And there should not be any bone destruction with this process. All right, last case. This was a 55-year-old man with back pain 1 month after surgery, inner body fusion. You can see on his sagittal T1 hypointensity here, a large collection in the prevertebral soft tissues. It looks like infection, doesn't it? Recombinant human bone morphogenic protein can have an appearance like infection. Now, this is not as commonly used as it used to be, but it still is used when people put in hardware and when they do spinal surgery in the lumbar spine especially. It used to be used in the cervical spine, not so much anymore. These are pictures from the literature that show kind of the comparison between what spondylitis looks like and bone morphogenic protein osteolysis looks like. And I would say it's somewhat difficult to tell, but they're saying in infection, you should have more diffuse enhancement, you can have epidural enhancement. If you have those things, it's infection. You should not have those things with bone morphogenic protein. So end plate osteolysis happens in all cases when you use this product. usually at 6 weeks. It's dependent on how much they use. Usually these patients do well, but then they come back a month or two after surgery with severe pain. They say it's self-limiting. You shouldn't do anything about it. But I know that's probably hard to do. People probably will want to biopsy this. It is an inflammatory response. So there's edema, and there's edema in the bone and soft tissue edema. And they can even have fluid collections around the spine. Now, in the worst case, it can cause subsidence of the graft, collapse around that graft, and they might need new surgery. But usually if they leave it alone, they'll be okay. You can also have the new bone formation, and we have to watch out because that can compress the canal or the neural foramen. So that's actually it. I'll wrap it up now. I've gone a little bit over time, but I'm very happy to welcome any questions or discussion of what you might see in your countries that might be more common than what I've showed you here.
Thank you so much, Wendy. This was excellent. It was an amazing talk. And the images were so clean too. I mean, I also learned, a few points, and I was like, oh my God, we should have done a spine talk before. I'm so glad you did it. Okay, so let me unmute people so that everybody can ask questions. And just like last time, if there are issues with the audio on your end, you can still ask questions by the chat. So there's a chat function in Zoom, which we discussed last time. It'll be pretty loud because we'll be unmuting everyone.
Getting out of the sun. There's some ads there.
Yeah. Okay. So any questions for Dr. Gibbs about this talk?
Hello? Hi. Hello?
Hi. Okay. So we have the resident that will ask who have a question, seems like. We can't hear you there. You want to say something and then we'll try, otherwise we'll try the chat. Sorry about the echo because we are in different continents, so. All right.
Anybody have questions?
I think
Maybe people can tell me what you see the most where you are.
I think they're typing. Do you guys have a question?
Oh, they're typing.
Yeah. Do you guys have a question? Otherwise, we can discuss what Dr. Gibbs is saying about what you see where you are. Dr. Bullowa, do you want to go and talk about your experience?
Me?
Yeah. It's like, why are people asking me questions? I'm supposed to ask questions.
Yeah, because almost after every 2 days, I'm seeing we are doing in our department of intervention radiology, we are doing biopsies and also putting some drainage tubes through the spine infections. So I thought the presentation was good and to the point.
Good.
Thank you. Thank you. Here, so we from Moha's residents, we are grateful for this wonderful session, Wendy. So they just sent this by chat. We don't have any questions today, but if any arise, we'll send it through Twitter or directly to Dr. Gibbs.
That sounds good.
Then Wendy, you had a question about the infections, right, from Moha's? The kind of infections which they see there?
Oh, yeah.
Okay. So can the residents at Mohas answer that question? Is the you saw the presentation, how, what is the infection profile for spine infections in Tanzania? Do you see a lot of tuberculosis, or what are the kind of infections do you see there? And then whoever answers that can just come closer to the laptop so that we can hear you well. Yes. Again, I think I can't hear you for some reason today that well. Maybe the chat is a good way to interact. Okay, and until then, I wanted to ask, I see Dr. Belova. I see some other people. Do you want to introduce yourself?
Yes.
I see somebody logged as an ACER. I also see Cherries. And then they said in Tanzania we get lots of TB, as spine infections.
Okay.
That's the answer which I'm getting here.
Does anybody see Cocci anywhere else in the world?
That's a great question. So the question is, does anybody see Coccidioidomycosis anywhere else in the world? We see here in parts of the US, as Dr. Gibbs discussed. But do you guys see it? Coccidioidomycosis. You can also reply by chat again. So Dr. Belova just said most of infections in Tanzania are TB, spine, and spondylolisthesis.
Okay.
So what about Coccidio, Dr. Belova and others? Do you guys see it here in Africa?
Because we usually don't take biopsies. Now intervention radiology has just started in Tanzania.
Right.
Most likely we will do much biopsies, and hence maybe we can come with those diagnosis later on. Yeah.
Right. Actually, that's a great point. Tanzania just started their first interventional radiology program, Dr. Gibbs.
Oh, nice. Yeah, good.
Yeah, it's very, very exciting. And the answer is, as Dr. Belova was saying, that once they do biopsies, they might be able to diagnose Coccidia if it's there. And it might be undiagnosed till now or something.
Yeah.
Like that.
Okay.
Yeah.
Well, good. Well, I'm going to have to go. I have to go do a biopsy in a few minutes, actually in a half hour. But if anybody has questions that come up, please do email me or on Twitter. Also, I will be watching, and I'm very happy to answer any questions at any time.
Okay.
And it looks like you're talking about me, but I can't hear you.
Yeah, I'm saying okay. Okay.
No, I heard you. I don't hear Bobby though.
Okay.
There you go. Now I can hear you.
Okay. All right. So thank you so much, everyone, for that. This was an excellent Grand Route, Wendy, and I really appreciate you doing this for us. And we'll be in touch with you through email or Twitter if there are any questions. But
very good. All right. Thank you very much.
Thank you so much. Take care.